Good day, and welcome to the 7th in a series of presentations on difficult-to-diagnose cases and the effects that accurate early detection had upon the life of a 40-year-old patient who underwent MCG testing over the course of 10 years. The purposes of this video are the same as previously. However, we have the immeasurably valuable opportunity of reviewing the case of a patient that was monitored and tested multiple times during two extremely clinically dense periods of his life. You'll notice that the information MCG provides is capable of bridging the microscopic and the gross anatomic structural descriptors of the human body by providing vital, dynamic, and complex functional expressions of its state mathematically. The first section of this video will be covering the patient's tests that were performed when he was 30 years old. He had Hodgkin's lymphoma at the time, which was treated with standard chemotherapy. He was tested before, during, and after his treatment and recovery on MCG, and then tested again 10 years later to monitor the risks of a suspected viral flu-like infection to hopefully better understand its immediate and long-term consequences. His initial MCG session scores were recorded as all zeros for his very first test prior to receiving treatment, along with the detected presence of very low-level myocardial ischemia in its early stages, defined by occasional local ischemia. Otherwise, his heart was considered completely normal by conventional standards. His secondary markers only showed incipient ventricular and atrioventricular arrhythmia, but considering his scores and his health prior to that point, there was nothing to particularly call much attention to. This, however, drastically changed during his chemotherapy treatment. Using MCG, we were able to detect acute cardiotoxicity throughout the course of his chemotherapy regimen, with his scores dramatically elevating to a 3.0, 7.5, and an 8.0, with alternating local and global ischemia, which placed him in category E at least, with signs of high myocardial ischemic burden. Meanwhile, as might be a theme for these videos, his routine EKG readings were still showing as completely normal. Secondary findings also uncovered acute myocarditis, 2/3 increased myocardial compliance, global asynchrony favoring the left side of the heart, various forms of arrhythmia, other structural anomalies, along with the onset of a more ominous ventricular arrhythmia. With only a few minutes per test at bedside, MCG was able to take this patient and quickly, accurately, and rapidly detect and pinpoint the number of cardiovascular problems his chemotherapy was causing in relation to his prior system's normal state. Luckily, he showed signs of recovery within 20 days, and 2 months after finishing his chemo, we found that the majority of his acute abnormal expressions resolved, which means that MCG was not only able to detect the sudden changes caused by the treatment, but could also, over time, track the resolution and, using mathematical outputs, gauge the degrees of recovery, and find any long-lasting signs of damage that may lead to worse prognosis when encountering other illnesses. We believe that treatment, care, and recovery of a patient is first and foremost an information war, and MCG delivers that information in a matter of minutes with objective, unbiased, and rapid accuracy that can be used anywhere in the world with a stable internet connection. These are graphical representations of the autopower spectra measurements of this patient's test sessions. We want to use this to demonstrate how the MCG analysis program analyzes the unique expressions of the cardiovascular system by breaking down electrical signals of the heart into frequency bands that can be measured by the analysis engine as such. From here, the engine measures the peaks, trows, interpeak intervals, and overall power output represented by the area under the curve from all expressible and readable peaks within the frequency spectrum. This function, impulse response, is useful for looking at the response of a system to an internal or external stimulus. It can be used to measure the myocardial compliance. When it's increased, that may mean that there is acute myocardial damage or myocarditis to ischemia. When it's reported as decreased, it may indicate myocardial hypertrophy or decreased stiffness of the myocardium due to inflammatory changes, just as a few examples. Here, MCG detects an acute increased myocardial compliance, indicating decreased stiffness of his heart, throughout the sessions leading to various expressions of his arrhythmia. These expressions were exclusively observed during the chemotherapy treatment and absent in his initial test session, and thankfully resolved in the two post-chemo sessions performed 20 and 60 days after his treatment. Interestingly, functional ventricular hypertrophy was reported in all 3 tests during and after his chemo. This type of dynamic myocardial remodeling may be useful to detect chemotherapy-induced acute heart failure. Moving along to his phase angle shift visualization, the expressions shown are both quite abnormal, showing significant shifts above the neutral line, especially at the lower frequency bands, indicating shifting towards the left side of the system functionally, probably due to his chemotherapy affecting his left coronary arterial tree. We believe that his various cardiac issues, all of which can be expressed mathematically via this function, were caused by the acute cardiotoxicity of his chemotherapy regimen. This level of precise information at such short notice was until now not available, but with MCG we now have a tool that can perform early detection of these dysfunctions to enable physicians and patients alike to make better informed decisions on how to assess the risks of heart failure and choice of chemotherapeutic agents, the doses applied to maintain patient safety, and what course of corrective actions should be taken to guarantee the patient's long-term health post-treatment. With cross-correlation, focusing visually on the results generated and shown in the graph, the session performed during chemotherapy shows a veritable wall of peaks, deviating greatly from more normal patterns of a healthier cardiovascular system, allowing us to better identify his state before, during, and after treatment. The supply and demand imbalance patterns were most likely caused by the acute cardiotoxicity, without anatomic coronary artery obstruction being involved. The transfer function can serve as the bridge to move from one better functional environment to a worse one and vice versa. The differences between the pre- and post-treatment measurements are again shown with visible differences for differential diagnosis, short, immediate, and long-term risk tolerance assessment, and disease prognostication. These colored heat maps of the multiple functions are very useful not only for visualization of the mathematical output, but also to act as a gateway to better machine learning development for pattern recognition and disease severity calculation, providing early warning for progressive heart failure and even sudden cardiac death. From what we observed, there were functional changes post-chemo that may be long-lasting, even 60 days out from the treatment, which will likely mean elevated risks of mortality and morbidity as a result of other factors that may arise later on in his life. But thanks to MCG, we have a much more accurate picture of his condition than we would with other tools, allowing us to better chart paths towards treatment options and preventative care to ensure his health towards the future. And finally, these mathematical structural element matrices collect the results of the functions described previously to create these patterns in a transparent and reproducible manner. The parameters demonstrated that there were more permanent functional alterations that took place with long-term implications that must be assessed when performing outcome studies on patients. In conclusion, for the first section of this presentation, the standard ABVD chemotherapy treatment, usually performed with below 400 mg per square meter dosages, being sold as an option with low risk with only delayed side effects, may be incorrect based on the evidence of immediate detectable cardiotoxic effects that were found and quantified by MCG within the short term and long term of the patient's health. While the reasoning behind these claims is unknown to us, we believe that while the overall recovery from this acute cardiotoxicity was complete for the time being, there were still signs of long-lasting functional changes, requiring long-term outcome monitoring to truly understand the effects of his treatment, along with cataloging the immediate impact it had upon his cardiovascular system at the time. If MCG discovered what other tools did not or could not, then that means it could stand as an extremely useful tool for the creation of better and less cardiac risky cancer treatments. At the age of 40, the patient asked to be tested again following his experiencing of severe flu-like symptoms that he feared may have impacted his overall heart health. The following slides demonstrate that MCG not only detected the long-term impact of his chemotherapy treatments, but also detected the functional changes during his symptomatic stages of his flu-like infection, and helped establish a newly updated baseline for his body, indicating early onset CAD during his recovery period. His test session in May of 2020 showed reproducible local ischemia, similar to his initial tests 10 years ago. However, the disease severity scores changed to 2.0, 2.0, 4.0, and 2.0, with similar secondary and tertiary findings as reported in his tests performed during his chemotherapy. As a note, he was demonstrating flu-like symptoms that day. Approximately 2 weeks later, free of symptoms, his follow-up testing showed a reproducible severity score of 3.0 throughout the entire session with a total of 6 tests performed, with a pattern of alternating global and local ischemia indicating functional ischemia without obstructive coronary artery disease, meaning that there was no need for an angiogram. One notable change is the persistent and reproducible presence of decreased myocardial compliance throughout the session. Cardiomyopathy may have been acute or at least subacute since it did not persist in a subsequent test session 10 days after. 10 days later, his next session showed a similar reproducible pattern with the exception of his now resolved cardiomyopathy. Additionally, an interesting on and off pattern of global ischemia favoring lead to functional territories emerged, occurring in his asymptomatic stage, resolving itself, then occurring again in the final follow-up session, indicating myocardial remodeling. Where once his body showed extremely good health, the flu-like symptoms he experienced were enough to send his body rocketing back to the state he was in during his chemotherapy treatment, possibly an indication of its permanent effects on his body. Focusing visually on the results generated and shown in these graphs from each session, we can see that even to someone inexperienced with MCG and its testing system, the visually represented mathematical functions show a clear difference between this patient's normal and abnormal states. The supply and demand imbalance patterns were probably the cause of the acute endothelial dysfunction, along with the cardiomyopathy without anatomic coronary artery obstruction involved. We can also explore the patterns of signs of persistent chronic myocardial remodeling leading to eventual heart failure as the accumulative impact of chemotherapy, viral infection, and aging makes its effect on his body. As time goes on, these patterns will probably worsen unless addressed properly. From what we observe in these colored heat maps, again, there were functional changes post-chemo that may be long-lasting. A doctor reviewing these results must consider the heightened possibility of eventual heart failure due to acute or chronic disease, with elevated risks of earlier mortality and morbidity as a result of infectious diseases, especially considering viral infections and, of course, the usual effects of aging. To conclude this presentation, we would like to review the following points. Firstly, MCG detected acute myocardial damage as a direct result of this patient's chemotherapy, contradicting claims made about its treatment having lower risks of impact on a patient's cardiac health. The system also registered his potentially long-term functional changes immediately and then confirmed them 11 years later. MCG also detected the myocarditis and cardiomyopathy in acute symptomatic stages of his flu-like symptoms and his recovery stages. It registered an early CAD at an intermediate stage in his follow-up testing sessions, which means that it can be very effective for accurate detection and monitoring of the short-term and long-term effects of chemotherapy, viral infection, and beyond, safely at bedside in a matter of minutes, at much lower cost compared to other more expensive and expert-driven testing modalities. MCG can also reveal the causes of ischemic heart diseases even on top of his complicated history of cancer, chemotherapy, and viral infection. Personalized monitoring to measure the ongoing primary lifestyle prevention measures he's taking after testing will ensure a safer journey for decades ahead, now that he and his doctors are armed with the information necessary to fight the battle for his health. I hope this presentation has proved useful in better understanding some of how our system performs its diagnosis, and how to best to use MCG to save lives and cut costs for patients and doctors alike. If you have any questions, feel free to visit our website or send an email to info@premierheart.com and have a wonderful day. Thank you for your time.